Welcome to the deep dive. Today we're diving deep into something your body absolutely needs, potassium. But too much. That can actually be surprisingly dangerous.
That's right.
Specifically, we're unpacking hyperkalemia. That's the medical term for high potassium levels in your blood.
Yep.
We've gathered some key info from medical texts, research excerpts, and our mission really is to cut through the complexity. We want to give you the essentials on why this happens, who's most at risk, what to look out for.
Mm-hmm.
Especially with the heart, right?
Absolutely. The heart is critical here.
And how it's managed. It sounds technical, I know, but understanding this stuff really helps you appreciate how delicate your body's internal balance is.
It really does. Potassium is just fundamental. Nerves, muscles, your heart beating relies on it. Usually the body keeps it super tightly controlled.
Right.
But when that balance gets thrown off, especially on the high side, things can get serious. And sometimes, pretty quickly. Our sources really lay out what serious means here.
Okay, let's get straight into it then. High potassium. How high are we talking before it gets that label, hyperkalemia?
So the standard definition is a serum potassium level over 5 millimoles per liter.
Okay, 5.
And, you often hear more about low potassium, hypokalemia, but the sources point out that hyperkalemia, even though it might be less common, it's often more dangerous.
More dangerous.
Yeah.
That seems backwards almost. Why is having too much riskier?
Well, the biggest worry, the primary concern, is the effect it has on the heart muscle. High potassium is, unfortunately, pretty strongly linked to cardiac arrest.
Wow.
It directly interferes with the electrical signals, the ones that keep your heart beating steadily.
Okay, so less common maybe, but the stakes are definitely higher. That's important. So who are the people most likely to face this risk? And what's actually going wrong inside to make potassium build up like that?
There are really three main ways this happens. Your kidneys are the big players that get rid of excess potassium. So, number one, if kidney function decreases, potassium can build up.
Makes sense.
Number two, you could get too much potassium coming in too quickly, say, through an IV or supplements.
Right.
And third, sometimes potassium that's normally tucked away inside your cells shifts out into the bloodstream into the extracellular fluid.
And are certain people just sort of more prone to those issues?
Exactly. Older adults, for instance, as we age, there can be a natural decrease in certain hormones like renin and aldosterone. These are involved in how the kidneys handle potassium.
Oh, okay.
Plus, older folks are more likely to have existing heart conditions, which can make them more sensitive to potassium's effects anyway.
Right, that adds up.
Then you've got patients with kidney injury, especially if it's untreated. If their kidney function, what we measure as GFR, drops below, say, 10 or 20% of normal,
Right.
well, their ability to regulate potassium is severely hampered.
That low, huh?
Yeah. And if they get an infection on top of that or take in too much potassium somehow, the risk shoots up. Also, conditions affecting aldosterone, like hypoaldosteronism or Addison's disease. Aldosterone helps you hold on to sodium and water, but importantly, it helps you excrete potassium.
So less aldosterone means
You hold on to potassium, it doesn't get flushed out properly.
Got it. So kidneys are huge. Hormonal balance matters, especially with age or kidney problems. Let's zoom in on the actual triggers. What specific things cause these pathways to go haywire? What are the usual suspects?
Well, this is pretty striking, actually. One of the biggest culprits. It's often things meant to help, medications.
Really?
Yeah, the sources say medications are a probable contributing factor in something like over 60% of hyperkalemia cases.
Over 60%. From meds, that's a lot. Which ones are we talking about?
They list quite a few. Potassium supplements themselves, obviously KCl,
Right.
but also heparin, certain blood pressure drugs like ACE inhibitors, some beta blockers too, NSAIDs, the anti-inflammatories.
Wow, common ones.
Very common. Immunosuppressants like cyclosporine and tacrolimus, used after transplants. And, really importantly, potassium-sparing diuretics. They stop you from losing potassium, which is good unless...
Unless you already have trouble getting rid of it.
Precisely.
That's a tricky balance with those diuretics.
It definitely is. And that ties right back into potassium supplements and also salt substitutes. A lot of those substitutes are just potassium chloride.
Right, I've seen those.
Using them carelessly, especially if your kidneys aren't working at 100%, well, that's a direct route to high potassium.
And the sources seem pretty emphatic about this danger.
Oh, absolutely. There's a specific warning. Potassium supplements are extremely dangerous for anyone with impaired kidney function. Full stop.
Okay.
And even if your kidneys are fine, Giving IV potassium too fast or taking really massive oral doses can just overwhelm the system. The kidneys can only work so fast.
So there's a rate limit,
Yeah.
essentially.
Exactly. And critically, patients who are already on those potassium-sparing diuretics, they should not be getting potassium supplements. That's just asking for trouble.
That is a really clear, important safety point. Okay, so besides taking in potassium, what else can make it build up or shift out from inside the body?
Acidosis is a big one. When your blood pH drops too low, becomes too acidic. Hydrogen ions try to move into your cells to buffer the blood.
Okay.
But to keep the electrical charge balanced, potassium then moves out of the cells into the bloodstream. It's like a swap.
A dangerous swap in this case.
Can be, yeah. And then there's tissue damage. Think extensive burns, crush injuries, really bad infections, or even when cancer cells break down rapidly after chemo, that's called tumor lysis syndrome.
Ah, I've heard of that.
All those damaged or destroyed cells release their contents. And guess what's inside cells in high concentration? Potassium. It floods into the extracellular fluid, spiking the levels.
Okay, so kidney trouble, meds, supplements, acidosis, major trauma. That covers a lot for actual hyperkalemia. But you mentioned something else the sources bring up. Pseudohyperkalemia, false high potassium.
Ah, yes. The pseudo part. This is super important because it's a lab artifact, not a real condition in the patient. The report says high potassium, but the patient's actual level is normal.
How does that happen? A lab error.
It's usually about the blood sample itself, how it was drawn or handled afterwards. Like if the blood draw was difficult, traumatic, that can damage cells right there.
Okay.
Or using a tourniquet too tight for too long, especially if the person is clenching their fists, that can break down red blood cells in the tube. Letting the sample sit around too long before testing, potassium can just leak out of the cells in vitro.
So it happens in the test tube, not in the person's arm.
Exactly. Other things too. Drawing blood from above an IV site where potassium is infusing. That's an obvious contamination. Or if someone has crazy high white blood cell counts or platelet counts, those cells can release potassium when the blood clots in the tube. There's even a rare genetic thing where red blood cells just leak potassium more easily in the tube after being drawn.
That's wild.
Yeah.
And the danger is, if you don't catch that, it's false.
You might treat it aggressively. Give meds to lower potassium when it wasn't actually high to begin with, and that could make their real potassium level dangerously low, which has its own set of serious risks.
Oh, wow.
So the sources are really clear. If you get a surprisingly high potassium result, especially if the patient seems fine, no symptoms, maybe a normal ECG, you have to recheck it, get another sample, verify before you intervene.
That repeat test is a crucial safety net. Okay, so speaking of symptoms and ECGs,
Yeah.
what does real hyperkalemia look like? And why all the focus on the heart?
Well, like we said, the heart is just the most critical organ affected. You might not see much on an ECG below a level of 7 milliQL, but once you get up to 8 or higher, you almost always see changes.
And what kind of changes? How does it progress on the ECG?
It's actually a fairly predictable pattern as the potassium climbs. Early on, maybe above 6, you often see these really distinctive peaked, narrow T waves, tall and pointy.
Okay.
You might also see the ST segment dip down and the QT interval shorten a bit.
Then what?
As it gets higher, the conduction slows down, the PR interval gets longer. Eventually, the P wave, that first little bump representing the atria firing it, can just flatten out and disappear.
Disappear entirely.
Yeah. And then the really scary part is when the QRS complex, the big spike showing the ventricles contracting, starts to widen and look weird, deformed.
Yeah, maybe.
That means the electrical signal through the main pumping chambers is severely messed up. And that can quickly lead to dangerous ventricular arrhythmias, like V-fib, and then cardiac arrest.
So the ECG is literally showing the escalating danger to the heart in real time.
It absolutely is. It's a vital sign in this situation. Now, beyond the heart, high potassium can also cause muscle weakness. Sometimes that pins and needles feeling, paresthesias, and occasionally GI stuff like nausea or cramping.
Okay. We've defined it, looked at risks, causes, the tricky false positives, and the warning signs, especially those ECG changes. How do doctors lock down the diagnosis? And then what's the game plan? How do they manage it?
Diagnosis really hinges on confirming that high serum potassium level, remembering to retest if it seems off, and then matching it with the clinical picture, especially those ECG findings.
Right.
And arterial blood gas, or ABG, can also be helpful. It can show if there's acidosis, which we know can contribute, and actually treating the acidosis can help lower the potassium level too.
Okay. And management. Where do you start tackling it?
Well, if it looks potentially serious, first steps are immediate. get an ECG right away, and draw another blood sample for potassium from a different vein, definitely not one with an IV running. Rule out that pseudohyperkalemia.
Makes sense. And if it's less urgent, milder cases.
Then you start with the basics. Diet is key. Restricting high potassium foods.
What sort of foods are we talking about there?
The lists usually include lots of fruits, vegetables, legumes, whole grains, meat, milk, eggs. Even drinks like coffee, tea, cocoa can have a fair bit.
So quite a lot of common stuff.
Yeah. Low potassium options would be things like butter, margarine, cranberry juice, ginger ale, sugar, things like that. You even need to be careful with some colas, apparently. Check the labels.
Huh. Interesting.
And of course, restricting any potassium-containing meds or those salt substitutes we talked about. Sometimes, for a mild case in someone on a potassium-sparing diuretic, just stopping the salt substitute is enough.
Okay. What if diet and cutting out supplements isn't enough?
Then you might need meds that actively remove potassium. Often these are cation exchange resins. Sodium polystyrene sulfonate is a common one. You take it orally or sometimes as an enema.
How does that work?
It basically binds to potassium in your gut, swaps it for sodium, and then you poop the potassium out.
Right.
But you need your bowels to be working normally for it to be safe. If someone has an ileus where the gut isn't moving, there's a risk of bowel perforation, so you can't use it then.
Important safety point.
Yeah. And they can deplete other things like magnesium and calcium. Plus, because they trade potassium for sodium, they can cause sodium retention and fluid overload. So you have to be cautious, especially in people with heart failure. There are newer oral resins, too, like Patermer, that work a bit differently but still bind potassium in the gut.
Right. So those are removing it via the GI tract.
Yeah.
What about the really dangerous levels, the emergency room situation?
Yeah, that's when you need faster action. 4V calcium gluconate is often the first thing given in an emergency. It works super fast, within minutes.
To lower the potassium.
No, actually, this is key. It doesn't lower the potassium level itself. What it does is stabilize the heart muscle, protecting it from the toxic effects of the high potassium. It buys you time.
It's like a shield for the heart.
Exactly, a temporary shield. The effect only lasts about half an hour. You have to watch blood pressure closely during infusion, it can drop, and monitor the ECG. If the heart rate slows too much, you stop. Also, extra caution if the patient is on digitalis, because calcium can increase digoxin toxicity risk.
Okay, so calcium protects the heart temporarily. What do you do while that shield is up to actually get the potassium down?
Good question. If there's severe metabolic acidosis, IV sodium bicarbonate can help. Making the blood more alkaline pushes potassium back into the cells. Plus, the sodium might help the heart too. This takes a bit longer, maybe 30 to 60 minutes to start, lasts a few hours. But you have to watch for fluid overload and high sodium, especially with large doses. ADGs help guide this.
Are there other ways to shift potassium back into the cells?
Yes, a very common and effective strategy is giving IV regular insulin along with hypertonic dextrose sugar water, basically.
Insulin, like for diabetes.
Same stuff. Insulin drives potassium into cells along with glucose. The dextrose is just there to prevent their blood sugar from crashing. This starts working in about 30 minutes, lasts several hours.
Okay. Anything else for shifting?
Beta-2 agonists like albuterol, the asthma drug, you can give it IV or nebulized, inhaled. It also shifts potassium into cells. It's pretty effective but temporary. And you need to be cautious in patients with heart disease because it can cause tachycardia, a fast heart rate, or chest discomfort.
So lots of ways to temporarily protect the heart or push potassium inside cells. What if the root cause isn't going away quickly? Like if the kidneys have failed?
Right. If the hyperkalemia isn't just a short-term problem and the body simply can't get rid of the potassium on its own, you need artificial removal. That means renal replacement therapy.
Dialysis.
Exactly. Peritoneal dialysis is an option, but more commonly for acute severe hyperkalemia, it's hemodialysis, hooking them up to a machine that filters the potassium directly out of their blood.
Got it. That's a really wide range of strategies, from just watching your diet all the way to emergency meds and dialysis. Lastly, how do we prevent this? Or keep a close eye on people known to be at risk?
Prevention really starts with identifying those high-risk patients. People with kidney disease are top of the list.
And then monitoring.
Close monitoring, yeah. Tracking fluid intake and output. Watching for any subtle signs, new muscle weakness, that tingling feeling. Checking their pulse carefully, listening for arrhythmias. Asking about nausea or cramping.
What about lab tests?
Absolutely essential. Regular serum potassium checks, obviously, but also keeping an eye on kidney function tests like BUN and creatinine, checking glucose if insulin is being used, and those ADGs if acidosis is suspected.
And prevention strategies circle back to.
Pretty much what we discussed, making sure patients really understand and follow any low potassium diet advice, being super careful with or often just avoiding salt substitutes, potassium supplements, and those potassium-sparing diuretics, especially in anyone with kidney problems.
And the sources mentioned a safety point again about giving IV potassium even when someone's level is low.
Yes, just reinforcing that even when you're treating hypokalemia, giving IV potassium too fast can still cause hyperkalemia. You can overshoot. So careful calculation of the dose, the concentration, the rate, and always using an infusion pump. These are basic safety rules to avoid accidentally causing the problem you're trying to fix, or worse.
Wow. We have covered a ton of ground today. Hyperkalemia, it's clearly not just a number. It's a potentially lethal condition, complex causes, kidneys, meds, acidosis, trauma.
Right.
It hits the heart hard. You got to watch out for those false positives. And the management is really layered, isn't it? From diet to emergency drugs to dialysis.
It really underscores how vital that potassium balance is and the intricate ways your body tries to maintain it, and what happens when those systems are overwhelmed or fail.
It really makes you stop and think, doesn't it? How everything is connected. Problems with your kidneys or hormones or common medications you might take, even just how blood gets handled. Any of it can throw off something as basic as your potassium level. It's it's a powerful reminder of the complexity and maybe the fragility of keeping everything in balance inside us.